welcome to the Preemie Chats. Preemie Chats is a program that is for healthcare professionals and parents to talk about what matters to you, to explore new ideas, and to learn together. I'm Fabiana Bacchini. I'm a Preemie parent and executive director of the Canadian Premature Babies Foundation, as known as CPBF, and I'm happy to be your host today. The foundation is a parent-led organization that helps families in and after NICU through education, support, and advocacy. If you have a heart for preemies, whether you are a family or a healthcare professionals, please check our website at canadianpreemies.org. There you'll find resources, the latest projects, and most importantly, a community of people who want to see our little babies thrive. If you're watching live today, please bring your voice to this table, leave comments and questions in the chat, and we'll try to address them during our program. It is through rich conversations like this that we can advance practice and learn together. And today we're going to talk about brain health in children born preterm, the impact of everyday experiences. In this talk, we'll begin by reviewing key aspects of brain health in children born preterm, which includes brain growth and development, as well as brain injury. We'll then discuss how everyday experiences in the NICU and beyond can impact brain development and neurodevelopment in preterm children. And I have here joining me live from Toronto, Dr. Thiviya Selvanathan, graduated from the McMaster University. She completed her Pediatric Neurology residency training at the Hospital for Sick Children at the University of Toronto. She's currently a Neonatal Neurology Fellow at SickKids and is completing a Ph.D. in Neonatal Neuroscience at the Institute of Medical Sciences under the supervision of Dr. Stephen Miller. Her research uses advanced brain imaging methods to study the links between brain injury and clinical factors, especially how we treat pain in babies. Dr. Selvanathan, thank you so much for being here with us today. I'm so excited about your talk. You always have so many important pieces of information for us parents to puzzle all together and how we can better support our babies.
Well, thank you so much for inviting me. I'm really, really excited to talk about this very important topic, especially ahead of Brain Awareness Week. So I'm really looking forward to talk about how the impact of everyday experiences, both in the NICU and at home, make an impact on brain health in children who are born preterm.
And just a reminder for everyone watching us live today, please do send your questions and your comments. And after her presentation, we're going to have a Q&A period. Thank you.
All right. Well, through my talk today, we'll start off by talking about brain injury in preterm infants. We'll then move on to talk about brain development, because brain injury is happening in the bigger context of brain development in preterm babies. And then we'll finally talk about how everyday experiences in the NICU and beyond impact brain development and neurodevelopmental outcomes in babies who are born preterm. So we'll start off with brain injury. Two of the most common types of brain injury we see in preterm babies are white matter injury, and here we have some examples of this on the left side of the slide, and intraventricular hemorrhage on the right side of the slide. So we'll start off by talking about white matter injury. And before that, it's important for us to think about some basic structures in the brain and where these are so we understand what we're looking at. So on the left side of the slide, we have a picture of the brain. Here we've taken a slice of the brain going this way. We're looking at the two sides of the brain, and we see that there's this area called white matter. It appears whiter, and this is because we have tracts that are carrying information from one part of the brain to the other, and these tracts are covered by fat, which we call myelin, and because they're covered by fat, they look white. So we call this white matter. And then you can see the other label is for areas of the brain called gray matter. And these are very important structures in our brain that are important for learning, for how we move, control of breathing, and so on. On the right side of the slide, we have a picture that was taken from an MRI where we've actually reconstructed all of these tracks that are in the white matter of the brain. And so you can appreciate that there are many, many, many connections in the white matter in our brain. When we talk about white matter injury, this is injury that predominantly affects the white matter in preterm babies. And when we talk about white matter injury in preterm babies, there are two main types. One is what we call cystic periventricular leukomalacia, or cystic PVL, and the other is punctate white matter injury. We don't see a lot of cystic PVL anymore with advances in how we care for babies in the NICU, but here we have some pictures of what this might look like in a baby. So the first picture shows this on a head ultrasound. The black area of the head ultrasound is the ventricles, and we'll be talking a little bit more about this today. The other parts are other areas of the brain. And in this ultrasound, we're taking a picture of the brain going this way. So we're looking at the two halves of the brain. And you can see that there are some small kind of round areas around the ventricles on both sides. These areas are cysts and are areas of brain injury. If we look at the image just beside, this is a brain MRI. We're once again taking a picture of the brain this way. So we have the two halves of the brain side by side. On this picture, CSF, or fluid in the brain, looks bright white. So the structures in the middle are the ventricles. And then we see these two cysts on either side. And those are areas of cystic periventricular leukomalacia, or cystic PVL. Now, if we look at the image on the far right of the slide, this is showing an example of punctate white matter injury in a preterm baby. So in this image, we've taken a picture of the brain this way. The top of the image is the baby's nose, and the back is the back of their head. And we're looking at both halves of the brain. And you can see that there are these small little bright white dots. And those areas represent areas of punctate white matter injury. So this is the more common type of white matter injury that we see in babies born preterm now. And we don't see a lot of cystic PVL. And it's important for us to understand the type because it also tells us a little bit more about what we can expect in terms of neurodevelopmental outcomes. So when we talk about cystic periventricular leukomalacia, based on groups of studies, or based on studies in groups of infants who are born preterm, we know that there might be an increased risk for spastic diplegic cerebral palsy. And this is because of the location of where these cysts are. So once again, on the left side, we have the brain MRI. Now in the middle, we're looking at a cartoon of the brain. So it's the same section. We're taking an image of the brain this way, and we're looking at the two halves. And the green lines on this actually represent all of the important motor tracts that carry information that control movement in our arms, our face, our mouth, and our legs. And the tracts that control movement in our legs are actually the tracts that are closest to the ventricles. So these are kind of in the inside part of these tracts. On this image, the areas in yellow represent the areas with the cysts. And I think you can see from this image that those areas involve the legs, mostly the tracts that involve the legs. And this is why we see this pattern of cerebral palsy most commonly in children who have cystic PVL. However, when we talk about punctate white matter injury, lesion location, so the location of this injury, is also important when we talk about outcomes. And here in this study, what they looked at was whether these little punctate lesions, so the white dots, were behind or in front of this line that passes through the middle of the ventricles. In babies who had lesions that were only behind this line, they saw that they did not have a higher risk for cognitive difficulties. But when these lesions were in front of this line, so more anterior, more towards the nose, they saw that in these babies, overall, there was a higher risk of cognitive and motor difficulties. We're now going to move on to talk about intraventricular hemorrhage, which is another type of brain injury that we see in preterm babies. And it's important for us to think about some key structures when we think about intraventricular hemorrhage. So one is the germinal matrix, and this is a transient structure. So this is a structure that's very important for generating important cells in the brain. So neurons and glial cells. So these are cells in the brain that are developing, and this germinal matrix generates these cells until about 25 weeks of gestation. And then slowly, closer to term, the structure gets smaller and smaller. Because of changes in blood pressure or related to kind of illness around the time of birth, the germinal matrix, which has some more blood vessels that are a little bit more fragile, might rupture. And here you can see how the germinal matrix, which is the structure in yellow, sits really close to the ventricle, which is the structure in purple. And when it ruptures or when there is a bleed, it goes into the ventricle. Intraventricular hemorrhage is something that we see more commonly in very, very preterm babies. So here we're looking at a plot of the percentage of babies born preterm, so very preterm, less than 32 weeks, in 2021 who had intraventricular or germinal matrix hemorrhage. And you can see that overall, the percentage of these babies decreases as the number of weeks of gestation increases. We're now going to talk a little bit more about the ventricles. So here in this image, we have a cartoon that shows our ventricular system. So the ventricles, what we call the lateral ventricles, are shown in red, and then we have the third and fourth ventricle shown in purple. And within the ventricles, we have CSF, which is really important for clearing things and is actually flowing around through these ventricles. The choroid plexus, which is shown in pink, also sits here as well. And so we have CSF, which is flowing through these ventricles, and we have the germinal matrix, which sits really close to the lateral ventricles as well. And this is important for when we talk about the grading of intraventricular hemorrhage and complications that might develop as well. So when you're in the NICU, you've probably heard the terms IVH grade. So is it grade 1, is it grade 2, is it grade 3, and so on. And so this is what they're referring to when they talk about grade. So in the first image, we have an example of a grade 1 intraventricular hemorrhage. And here we're looking at an ultrasound that was taken like this through this plane with the two halves of the brain side by side. The arrow is pointing to this bright area on the head ultrasound that corresponds to a hemorrhage. And this hemorrhage is within the germinal matrix. And when we have a hemorrhage that's within the germinal matrix, this is a grade 1 intraventricular hemorrhage. In the second image, we have a grade 2 intraventricular hemorrhage. And in grade 2 hemorrhages, we have now some blood that's within the ventricle, but we don't see that the ventricles are dilated, so they're not big. So in this picture, we've taken a picture of the brain with ultrasound going this way, down the middle. And the bright area, again, shows areas where we have hemorrhage. And these are also shown by the arrows. The black part of this in the middle is the ventricle. And so now we see that there's not only hemorrhage within the germinal matrix, but we're also seeing some hemorrhage inside the ventricle as well. But we don't see that the ventricle is big. In the third example, This is an example of grade 3 intraventricular hemorrhage. So in this, we have intraventricular hemorrhage within the ventricle, and this is causing dilation of the ventricle. So the ventricle itself is getting bigger. So if we look at this picture, this is a head ultrasound, and we're taking a picture down this way. And the bright area is actually blood. And it's a bit hard to see in this picture, but that blood is actually within the ventricle. And the ventricle itself is also big. So this is an example of grade 3 hemorrhage. We can also have complications that can happen as a result of intraventricular hemorrhage. And one of these complications is periventricular hemorrhagic infarction. So this happens usually in the context of intraventricular hemorrhage, which impacts how the veins around our ventricles are draining blood. So this intraventricular hemorrhage compresses that vein. It impacts venous drainage or flow through the veins, causing congestion. And because of that, we can have a bleed within the area of the brain close to the ventricle. And that's why we call it periventricular, meaning around the ventricle, hemorrhagic infarction. And if we look at the picture in the middle, we're looking at this on a head ultrasound where we took a picture of the brain this way. The arrow is pointing to the area of PVHI that's bright. We also have an example of this on a brain MRI. Here we've taken a picture of the brain going this way, and we're looking at the two halves of the brain again. And you can see that there's this kind of triangular shape change in the brain over here, and that is the area of PVHI. So PVHI is one complication that can happen with intraventricular hemorrhage. Another complication that can happen is post-hemorrhagic ventricular dilatation, or PHVD. So we had reviewed the ventricular system before. We have our lateral ventricles and the third and fourth ventricle. These are all connected, and we have CSF flowing within all of this. What can happen sometimes is after intraventricular hemorrhage, the blood itself, or sometimes there can be scarring of the choroid plexus. This affects how the cerebrospinal fluid flows and how it's reabsorbed. And when this is blocked, for example, you could have a dilation of the ventricles, and that's what we refer to as PHVD. So in our head ultrasounds here, we're taking pictures of the brain going this way, looking at the two sides. In the first, we have an example of normal ventricles. The ventricles look pretty small, but in the example on the right, we're looking at dilatation of the ventricles, meaning enlargement of the ventricles. And the ventricles are these black spaces that we see within the brain on the head ultrasound. So another complication that can happen as part of intraventricular hemorrhage is PHVD. And this is an important complication for us to monitor for, and is why babies who have intraventricular hemorrhage will have repeated head ultrasounds as part of their screening. When we talk about neurodevelopmental outcomes in babies who have IVH, babies who have grades 1 or 2 IVH may have very similar outcomes compared to babies who don't have IVH. But sometimes it can differ based on whether there is other types of brain injury, such as white matter injury, that's also present. When we have babies who have grade 3 or 4, a grade 3 IVH or PVHI, so periventricular hemorrhagic infarction, there can be a higher incidence of motor and cognitive difficulties. And the motor difficulties can be related to location of injury. And we'll go through that in a little bit more detail here. So here we're looking at a picture of the brain MRI. We're taking a picture like this, and we're looking at the area of PVHI, which is that triangular area. In the middle, we have a cartoon of our brain again, showing important motor tracts. This time, we're just looking at half the brain, the half with the area of PVHI. The blue part on this picture represents that area of PVHI. And as you can see here, it's impacting the motor tracts for both the arm and the leg that are coming down on that side of the brain. But we don't have PVHI on the other side, and so we don't see anything on that side. So we know that one half of the brain will control motor movements in the other half of the body. And so in this case, if we have injury on the right side of the brain, then we might expect to see changes on the left side of the body. However, it's important for us to remember that not all babies with PVHI or with white matter injury develop cerebral palsy. And so here in this study, they actually looked at the association of PVHI with neurodevelopmental outcomes. They looked at how many babies with unilateral, meaning PVHI on one side of the brain, or bilateral, meaning both sides of the brain, actually had cerebral palsy. And as you can see, this number is not 100%. And outcomes really vary. They might depend on the size of the injury and the location of the injury. And we'll talk a little bit more about how brain development and other factors also impact neurodevelopmental outcomes. So we've talked about brain injury, but I think it's really important for us to think more broadly at brain development. Here we have 3 pictures, so 3 MRI pictures that were done in the same child. The first MRI was done when this baby was around 30 weeks gestation. The second MRI was done when this baby was around term age. The last MRI was done when this child came back for follow-up at 8 years of age. And I think you can appreciate from these scans that they actually look really different. So during this time, we see that there's an increase in the size of the brain. We also see that there is an increase in the folding. So if we look at the first MRI, it's quite smooth. We don't see a lot of lumps and bumps, but you can see over time how the brain becomes more lumpy and bumpy, especially when we're looking at the brain at term compared to the brain at 8 years. We see that these lumps and bumps are a bit more similar. So there's a lot of changes happening during this early period of brain development. We also talked about myelin. So myelin is that fat that surrounds our white matter tracts. And this is a process that happens over a couple of years. So in our first scan, we don't see that there's a lot of myelin, but if we look at 8 years, because of the way the sequences were acquired, myelin is actually black on all of these sequences. We could see that there's a lot more black areas within the brain. So we see that there's an increase in myelination over this time. And what we don't see on these MRIs are actually the connections that are being formed over this period of time. And so there are lots of changes happening in the brain over this period, both when the baby is in the NICU and when the baby goes home and is home with you. So we'll start off by talking about how everyday experiences in the NICU can impact brain development. And when we talk about everyday experiences, these include things like pain, exposure to ventilation or type of ventilation, nutrition, infection, hypotension, and treatment of pain, and there are many other things that I haven't even listed here. Today, we'll focus on a couple of these factors, but there are many factors that impact brain health in preterm babies when they're in the NICU. So in the NICU, we have brain care bundles, and these are clinical practice strategies for preventing brain injury that we typically do in the first 72 hours of life. And these might include things like keeping the head in midline position, so keeping the head in the middle, elevating the head of the bed to 30 degrees, minimizing how many times we're touching the baby and how many times we're poking the baby for painful procedures, and also include some strategies to try to prevent big changes in blood flow to the brain, and also blood pressure in the body. So these are all strategies that focus on preventing brain injury in preterm babies. We know that pain is also very important for brain development. And there have been several studies now to show that repetitive exposure to pain early in life, so in the initial weeks after birth in a baby born very preterm, can affect the brain and neurodevelopment. So these studies have shown that more exposure to pain early in life is associated with changes in the brain white matter, as well as changes in important structures in the brain called the thalamus, which is the relay center in the brain, and where information about pain and sensation is all coming through. So we see that this is related to changes in that region in the thalamus, and is also related to how this brain region is connected to other brain regions. So thalamocortical connectivity. We also see that these changes in the brain that are related to pain exposure are associated with neurodevelopmental outcomes when we see children back in follow-up. So pain is important and very important for us to think about to try to promote brain health. And what's important about pain is that it is a modifiable risk factor. And so in this study, what they did was they looked at whether leaving in a central line or an arterial line in for longer made a difference in terms of the number of painful procedures that babies were exposed to, changes in their brain, and changes in development. So what they did was they compared brain MRIs, neurodevelopmental outcomes in children at two different sites. At one site, they typically leave lines in for longer, while at the other site, they typically take lines out as quickly as possible to try to minimize risk of infection. What they saw was that with the use of lines by leaving them in longer, this was associated with a decrease in the number of painful procedures that babies were exposed to. What was also really interesting and shown in this graph here on the right is that the thalamus volumes in those babies at the site where they left the lines in longer were also bigger. So these are all the little triangles on the plot, and you can see how these thalamus volumes are bigger than the ones with the circles where the lines were taken out more quickly. So leaving in the lines for longer was associated with less painful procedures and higher brain volumes in the thalamus, which is this important relay center in the brain that has all this information about pain and sensation passing through it. What they then looked at was whether those changes in the thalamus were associated with neurodevelopmental outcomes. And what they saw was that greater thalamic growth in babies born very preterm was associated with higher motor and processing speed scores at school age. So pain is a modifiable risk factor, and it's important for us to think about pain in the NICU. I'm also going to talk about the study looking at mechanical ventilation. So here they looked at a group of very preterm babies, and they looked at the duration of mechanical ventilation. And they started off by first looking at whether longer duration of mechanical ventilation was associated with changes in the brain. And what they saw was that with longer duration, they saw smaller volumes in important structures of the brain that are important for control of our breathing. So this includes the pons and the medulla, which I've kind of circled in this image here in purple. So longer duration of mechanical ventilation was associated with smaller brain volumes in these key structures responsible for our breathing. They also saw that longer duration of mechanical ventilation was associated with changes in white matter microstructure and development. They then looked at whether mechanical ventilation was associated with neurodevelopmental outcomes. And here we have a plot of days of mechanical ventilation by movement ABC, which looks at motor development at 4.5 years. And here we've plotted this. So if we look at this plot, we see that with greater duration, so increased days of mechanical ventilation, there were lower movement ABC2 total scores, so decreased motor scores at 4.5 years. So mechanical ventilation is also important for brain health. Finally, I'd like to talk about this really interesting study that was done in the NICU. And this study focused on the mother-infant emotional connection in the NICU and how this is related to early brain development. So they did this through a family nurture intervention. So this intervention aimed to promote mother-infant emotional connection and physiologic co-regulation. Basically, what this involved was as soon as possible, if the baby couldn't be picked up, then they exchanged scent cloths. So the mom had a cloth that was with the baby scent, and baby had a cloth with mom scent. They encouraged firm and sustained touch of the infant while the mother spoke to the baby about her feelings, what she was feeling in their native language. When they could pick the baby up, there was a lot of skin-to-skin holding while speaking to the baby about mom's feelings, and mom would also make eye contact with the baby as often as possible. In one study, they looked at how this intervention, this family nurture intervention, was associated with neurodevelopmental outcomes at 18 months. So here we're looking at the cognitive score at 18 months. SC is standard of care, FNI is family nurture intervention. And they saw overall that there was an increase in cognitive scores in babies who had the family nurture intervention. And it wasn't just cognitive, but also behavioral scores as well. What was also really interesting is in another study, they actually looked at brain connectivity. They used EEG to do this, which allows us to look at how different regions in the brain are connected with each other and communicate with each other. And in this study, what they saw was that the family nurture intervention was associated with changes in the brain in babies. So here we're looking at a plot of connectivity in 3 groups of babies. SC is standard of care, FNI is family nurture intervention, and HC is actually a control group of term infants who also had no intervention, but where they measured brain activity. And what's very interesting was that in the babies in the family nurture intervention group, the connectivity was very similar to the babies who were born full term. There were no differences between those groups. But in the babies who received standard of care, they did observe a difference in connectivity between those babies and the babies born at term. So the mother-infant emotional connection in the NICU is associated with neurodevelopment and with changes in brain connectivity. So we've spent some time reviewing how everyday experiences in the NICU might impact brain development, but we know that the home environment is so important when it comes to neurodevelopmental outcomes and brain health. And so we'll review a few kind of key studies in this area today. So the first is looking at how the home environment might modify neurodevelopmental outcomes after brain injury. So this study was done in a group of very preterm babies who came back for neurodevelopmental assessments at 4.5 years of age. These babies all had brain MRIs as part of this research study when they were babies in the NICU, one in the initial weeks after birth and then again at term equivalent age. And here we're looking at a plot of their cognitive outcomes, and we've separated out the babies based on maternal education, and we use this as a marker of socioeconomic status. So the orange lines are babies who were born to mothers in the highest socioeconomic status group, so they had completed a postgraduate degree. The blue is mothers who had completed an undergraduate degree, and the black is mothers who had completed primary, secondary school education. We also have solid and dashed lines. The dashed lines represent babies who had brain injury, while the solid lines represent babies who didn't have brain injury. So I think there are a few important points here. So one is, if we look just overall without separating based on whether the babies had brain injury or not, we saw that the cognitive scores were highest for those babies in the highest SES group. If we now focus on the blue and the black lines, we saw that there was a difference between the babies who did and did not have brain injury in terms of their cognitive outcomes in these two groups. So you could see that the dashed lines are lower than the solid lines in these two colors. But what was very interesting was that if we looked at the babies in the highest SES group, the orange lines, the dashed and the dotted lines overlap. There was no difference there in terms of cognitive outcomes in babies who did and did not have brain injury. And this really tells us how important the environment is in modifying outcomes after brain injury. Unfortunately, we did not get a lot of detailed information about what was specifically impacting neurodevelopment in the environment. But I think that this is an area of research that we need to think more about. What specifically in the environment contributed to outcomes is something that I think we need to understand better. Here we have another really interesting study, also looking at the impact of the home environment on neurodevelopment. So this was done in a group of babies with congenital heart disease, and this was in toddlers, so they were between 2 to 3 years of age. And babies with congenital heart disease, like babies born preterm, are also at a higher risk of neurodevelopmental disability and brain injury. And in this study, they looked at the relationship between the home environment and cognitive scores at 2 years of age. And they used this scale called the Cognitive Stimulating Parenting Scale. And this was a survey that was given to families to understand more about the home environment. And this parenting scale survey had questions about various things in the environment, including what the child had access to. So did the child have access to toys that taught them about shapes and colors, for example? It also asked questions about parent interactions with their child. So how often did they read to their child, for example? Did they teach their child about colors or animal sounds? Those were some examples of questions. And it also asked about access to various things in the home environment, such as how many books were in the home and how often they were reading as a family. And what they saw was that a higher score on this scale, so a more cognitively stimulating home environment, was associated with higher scores on the Bayley scale in terms of cognitive development. And so once again, this really highlights the importance of the home environment in promoting brain development and neurodevelopment. Finally, I'd like to talk about this really interesting study and initiative that's being led by one of our neuropsychologists at SickKids, Dr. Tricia Williams. It's called the iInteract North program, and it's a virtual parenting intervention for children who we follow in our neonatal neurology clinic, including children who are born very preterm, who might have some behavioral and emotional problems. And Dr. Williams implemented a virtual parenting intervention to target these problems through modifying parenting behaviors. And here we're looking at plots of both the intensity of these problems, which are shown in red, and the total number of problems, which are shown in blue, before and after this parenting intervention. And I think you can see here that it's pretty striking, the difference before and after. That after the intervention, there was a reduction in both the intensity and total number of problems or problem behaviors or emotional problems after the intervention. So I think this is a really interesting study, and also, once again, reiterates the importance of the home environment in terms of neurodevelopment. So I hope that through my talk, we've kind of focused on these few kind of key areas in brain development. Through my talk, we discussed that brain injury is common, but that outcomes vary. We also talked about the importance of focusing on promoting brain development and how everyday experiences, both in the NICU and at home, matter and impact brain development and neurodevelopmental outcomes in children who are born preterm. I'd like to end by thanking the many children and families who participate in our research studies. I'd also like to thank Fabiana again for inviting me to speak today, and I'd be happy to take any questions.
Hi, Thiviya. Thank you so much for your presentation. Always so enlightened. And thank you for sharing all these amazing studies that are happening across Canada. So we do have a question from our live audience, and I'm going to go there first. I think the question got cut off, but I think you can answer the first piece. Does venous delivery can cause IVH? Believe it's a vacuum delivery, because recently my unit, the infant was admitted at 36 hours. So we don't know the rest of the question. But I think the first piece, is it something that you can help out and answer that question?
Sorry, I missed the first part of the question. All I heard was, here. Does venous delivery cause IVH? Because, so I think it's challenging. I don't think that there have been studies to clearly show that a venous delivery or vacuum-assisted delivery is associated with IVH. Particularly in an infant who is born later, we think about other reasons for why they might have had intraventricular hemorrhage, such as problems with bleeding or clotting disorders, or if there is a clot in the venous system in the brain. These are all important things that we like to think about when we see IVH in a baby who's closer to term.
Okay, so she just added the rest of the question here. Let's go back. So recently, my unit, an infant admitted 36 hours of life after he demonstrated seizure, had ultrasound done, grade 3 IVH, MRI was done, also bilateral IVH. Physical examination, no. Okay, now you have to read that word, the big word. Cephalohematoma, is that right? Other question, yeah. What is the other differential diagnosis?
Yeah, so I think we've just spoken about the other differential diagnoses for this problem and other things to consider. I think it's also really important to think about the gestational age of the baby and whether this is something that we see more commonly at that gestational age, because we see that intraventricular hemorrhage is something we see more commonly in our very preterm and extremely preterm babies rather than interim babies.
Okay, so let's go to the brain injury and the bundle that we are talking about, because it seems that it's spreading across Canada to have the 70-hour bundle. So what have you seen on the last few years? Have you seen any difference? Or maybe you could talk a little bit about the bundle, because I have Dr. Khurshid Mohammed with us a few weeks ago. He was talking about the bundle, but can you talk a little bit about that and what have you seen in clinic?
Sure. So my research mostly focuses on white matter injury. I'm not sure that it's completely related to the bundle, but we're hoping to share, we're hoping to get this work published as soon as possible. But we've noticed that over the last decade and a half in our cohort of babies who we followed, that there has been a decrease in the size and the severity of white matter injury over time in very preterm babies. It's hard to say exactly what's caused this, because we know that there have been so many changes in how we care for babies over time. But I think this is something that's really positive, that what we're doing is working. We're seeing that there's less white matter injury over time, and we're seeing that the white matter injury is less severe as well. So I think that it's probably a combination of many different things that we're doing, like how we're ventilating these babies. We pay more attention to infection and treating infection. We pay more attention to pain and managing pain in these babies. The institution of brain care bundles. There have been so many things going on in the NICU over the last couple of decades, but it's good and it's positive. And I think that it's something that's really exciting.
Absolutely. And for me, as a mom who has a child who had cystic PVL and he has quadriplegia cerebral palsy, to hear the advancements now and see the kids will have other outcomes, it's very promising and very exciting. So let's talk about the diagnosis, because when you have a brain injury in the ICU, and I see a lot of parents in our parents group that, my baby had a grade 4 IVH, and the doctor said he might or she might have cerebral palsy or other disabilities. Is the NICU the right time to give such a diagnosis? Because we always discuss it among us parents, right? Because you also said we don't know, right? The outcomes can vary, and you show some images that babies who had injury, but depends where the location was, it didn't show as cerebral palsy. So in your perspective as a neurologist, which might be different than neonatologist, how do you feel about this breaking this difficult news for parents, or giving parents the possibility of the babies having a disability? Or specifically, I think cerebral palsy is what the word that is always on parents' radar in the ICU.
Yeah, definitely. I think that I probably have a different perspective as someone who tends to see children in follow-up and in clinic. And, I have the perspective and the luxury of following families over time and seeing children over time. So I can see how they do over time. I think that there have been some more interesting papers and studies coming out in this field around parent perspectives on, one, how to communicate this information, what the best timing would be, what setting this should be done in. I think that it's challenging because we want to have families be prepared for the future, but we don't want to take away hope, because nothing is 100%. And I think that through some of the studies that I've presented today, the home environment is also really important in modifying neurodevelopmental outcomes. Early interventions are also really important in modifying neurodevelopmental outcomes. What I tell my patients is that even after a diagnosis with cerebral palsy, your child is still your child. It's not, they're still the same person. They still do the same things that they do the day before we spoke about this diagnosis. It's a label that allows us to communicate amongst each other in terms of what we're seeing, the differences in their motor development and motor function we're seeing, and what supports that we might be able to provide to best support their development. So that's usually how I try to frame that discussion. I think it's a different perspective, because usually this diagnosis has already been given by the neonatologist and neonatal follow-up clinic when I see them in neurology clinic. So it's a different perspective, I think, that I have, but I think we do need to be mindful, I think, about how we have these discussions and the setting in which we have them. And I think this is where having your perspective as a parent and the perspectives of other parents and families who have been through this is very important.
Absolutely. And I like the way you say, like, it's the way you frame what it is for the families. because I always feel like, yes, you can set up our journey, right? You can help us to set the journey ahead with hope or totally despair. And I think the way you communicate that with families is really, really important. So, but I have a question for you in regards to this the importance of every day, because we did talk about the importance of every day in the NICU and the importance of every day at home. In the NICU, parents don't have full control of the environment, right? Because the babies do have to go through the procedures and the pain and all that. But you did mention a few things that I took notes here: the same cloth, the touch one, that you cannot do skin to skin immediately, how you talk to baby, how you interact with your baby, about your feelings.
Yeah.
So talk to me about that, because I'm very curious to know, talking to the baby about the weather, talking to the baby about how I feel as a mom, or just talk to the baby, because we know it's going to promote her language development later on. But it's so, and you talk about how much we advanced in care in medical care, but we also advance care on parent engagement in the NICU and presence in the NICU. So talk a little bit about that piece of what parents can do in the NICU.
Yeah, so I thought the studies that I had presented on that intervention were very interesting. So those studies really focused on the mother-infant emotional connection, and they actually had I believe it was a nurse or someone who really kind of specialized in encouraging families to build that connection between that emotional connection between the mother and the baby. And that was why there was that focus of, even while you're holding baby, talk about your feelings, talk about your emotions in your native language to your baby. So I thought that was really interesting. But I think even if it's not focused on just talking about your feelings, we know that just skin to skin, talking to your baby, these are all really important interventions to support brain development. And these are things that can be done while the baby is in the NICU. They can be done in the inpatient setting. So like you said, I think in terms of medical care, things have really advanced. We're starting to now think more about patient engagement and parent engagement in the NICU, and how this impacts brain development. These are some initial studies that looked at this in terms of neurodevelopment and brain development. And so it'd be really interesting also to see how children do over time after the implementation of this intervention. But yeah, I thought it was very, very interesting and just fascinating to see how that connection can impact brain activity in babies.
It is pretty incredible to think about it. And on the other side, like, we're still advocating for parents to do skin to skin in the NICU. I mean, in Canada even, but in so many other countries, it's still a practice that is not a standard of care in many locations. And I think that we should be pushing hard to have that contact. There's so much evidence out there promoting skin to skin. But when I hear you talk about this study that has actually, all the bundled together, how parents can engage and hold the baby, it makes such a difference in the brain.
Mm-hmm.
So let's talk about the home now, because the NICU is a period of our time, right? And then you have home, which is the rest of our lives with that child. So I love the studies when you talk about simulating what kind of environment you provide to your child at home. Let's talk a little bit about that for the families who are listening to us today. What kind of environment they can create for their babies?
Yeah, so we can talk a little bit about this today, and some of the resources that we will share after the talk will also have more information about how you can do this at home. And these are general tips and strategies that support brain development in all babies, not just those who are born preterm. But we know that things like reading to your baby is so important and really supports language and cognitive development. We know that limiting screen time is also very important. Spending time outdoors, playing together. these are really important too. And in the resources that we share, there are also some information about the types of toys that are really helpful. They don't need to be fancy toys, but even things like, for example, we know when babies are really little, they don't see pale colors. So using high contrast books when babies are little, black and white. That's what they mostly see when they're young. And then they start to see color when they're older. So they give some examples of toys that are appropriate for the age of your child and the resources that I shared. But I think those are the most important things: reading to your baby, playing outside, tummy time when your baby is younger. Lots of great things that you can do to support their development at home.
Yes, and I remember when my kids were little, I had all these beautiful toys, and they like the kitchen gadgets.
Yeah, exactly.
We need fancy toys. We need a lot of kitchen gadgets for the kids. And but I am sharing all the links that you share with us on the comments on Facebook and YouTube, so people can have a live access to those links, because the websites are full of resources. They are amazing. So thank you for sharing them with us. So we did talk to Trish Williams a few weeks ago about the Interact North project, and let's talk about the behavior and emotional things for the children. But we also talked about the parents' emotions and how that reflects on the way we interact with our children and the way they can further develop.
Yeah.
So
yeah.
Talk to us about that, please, because
I
feel that is an ongoing conversation.
I think so. I think it's an ongoing conversation. Dr. Tricia Williams is certainly an expert in this, and she's the one we refer our patients and families to when they come to us with concerns. I think it's not uncommon that families, when we see them in clinic, they're a bit frustrated. They're a bit guilty also about feeling frustrated, about the behavior and emotional concerns or challenges that their child is having. So it's why I'm really excited about this intervention, and also the fact that it can be done virtually. It's something that my patients have been really interested in going through and hearing more about. So I really hope it's something that Dr. Williams is able to scale up and provide to more families, because in clinic, this is one of the major concerns that I hear, that there are behavioral or emotional concerns at home that affect not just the child, but the entire family, including interactions with other children in the family, siblings, and also how the parents feel about themselves. There's also some guilt around wanting time away or wanting time for themselves or wanting a break. And so I think there's a lot of pieces that play into this: parental mental health, the mental health of the child, the behavior in the child, and all of these things impact neurodevelopment and brain development as well, and the family as a whole.
So when do we start seeing this behavior and emotional issues with children? Is it not in a baby stage, or is it?
No, so we tend to see usually when the children come back for follow-up, usually around school age, is when we start to hear more concerns about behavior and emotional issues from families. So usually around 4 or 5 is when we tend to hear more of these concerns for families.
So if your families don't have a follow-up with neurologists, where they can go for this kind of follow-up? Because we see a lot of comments from families on our group that the babies, the children now who are born preterm, are showing the signs of behavior, especially the first few years of school. And the school obviously a lot of times don't know how to manage, don't know what to do. They don't have the history that the baby was born preterm. And families are pretty much desperate for help. So where can they go? What kind of resources and access they can have?
So I think the best person to reach out to first is your family doctor or your pediatrician. They might be able to suggest some resources themselves that are kind of local to your area and supports for your family. They might also suggest seeing a child psychiatrist, for example, or a psychologist for an assessment. The SickKids website also has a lot of resources through their community mental health program. So that would also be a great place to start and take a look at as well if you live close to SickKids and are in Toronto. But I agree, I think this is a big issue, and we know that mental health is a big issue in children that was exacerbated by the pandemic, and really an area of need in terms of further research and supports for families.
Absolutely. But Dr. Selvanathan, thank you so much for joining us here today. It's always great talking to you, and you really shine light in our lives and the lives of people, families will come after us, and the future looks much brighter. What you show today with research, what we learn, how we've been progressing in care for our very preterm baby. So thank you so much for being here with us today.
Thank you. Thank you so much for inviting me.
And to all of you watching us live today, thank you so much for joining us here today. And I want to thank also our sponsor, AstraZeneca, for their ongoing support of our life education sessions. And just a reminder, if you missed part of today's session, or head over to our website, thecanadianpreemies.org. I'm going to share right here. And to see the full episode and also all the past sessions of the Preemie chats. You'll find many resources on our website. And just a reminder that CPBF is a charitable organization and depends on your support to continue its important work. Consider how you can support CPBF and its mission to empower families of premature babies in every step of their journey. Together, we can create a brighter future for all preemies and their families. And we will see you again next Friday, 1 p.m. Eastern Time. Stay well.